There are several other trials that are looking at novel combinations and also looking at combinations in specific subsets of patients. The Calypso data of savolitinib, which is a potent c-Met inhibitor combined with durvalumab, were just recently presented in patients with papillary RCC, demonstrating response rates of around 26%. So it's exciting to see variant histology RCC being represented in clinical trials, as those with non-clear cell disease are largely unrepresented in most of these studies. They were exclusive of patients who had a clear cell component. And I think looking at studies that really highlight the efficacy of these agents in non-clear cell patients will be important. The CONTACT-03 trial of atezolizumab plus cabozantinib will include patients who have or papillary and unclassified RCC. There's also a trial called CANI of nivo-ipi plus cabozantinib, looking at that combination in patients with non-clear cell histology. Another unmet need is patients who have bone metastases from RCC. We know that those patients have declines in their quality of life and also decreased mortality or decreased survival. And so we've designed a specific trial through the Alliance Cooperative Group, myself and Dr. Shariri, which is now open and accruing patients of the combination of cabozantinib with or without radium-223, which is a liquid radiopharmaceutical that specifically targets the bone metastases in the bone marrow niche. And it'll be exciting to see about new drugs with the new mechanisms of action in this patient population. Additionally, I think questions that are being asked are, does everybody need frontline combinations? Frontline combinations, should those be given for everyone? We know that the toxicity rates on the order of about a third of patients who require the need of high-dose steroids to treat immune-related toxicity. And can we adapt our trials to response? So if a patient is, having a dramatic response to therapy, can we safely stop therapy? Or if patients don't have a response to checkpoint inhibition monotherapy, nivolumab monotherapy, can we layer in a CTLA-4 blockade with ipilimumab? So there's 3 trials that are specifically looking at this exact question and different iterations of sort of adapting checkpoint inhibition therapy. One of the trials was recently presented at ESMO last year called the Titan trial that looked at adding ipilimumab for 2 doses when patients did not have a response, an objective response to nivolumab alone. And then if there was a persistent PD or SD, then an additional 2 doses were added. I think, it's hard to interpret some of the trials because they included very heterogeneous patient population, both frontline, second-line treated patients. But it seems to be like the delta from the Titan trial that was presented was about 10%, that the added rescue was probably about 10% with the addition of IPI to patients who were non-responders to nivolumab. We're awaiting the data from Omnivore, which was a multi-center IIT that was run through the Dana-Farber with colleagues Dr. Shariri, David Braun, Brad McGregor, that's looking at answering the question of following induction with nivolumab alone. Based on response, can you stop nivolumab treatment in those patients who have a confirmed CR or PR? Or if they did not have a response, actually adding in 2 doses of ipilimumab. And there's another study that's being coordinated through HCRN with the PI of Dr. Michael Atkins that we're also waiting for, of looking at the role of almost salvage ipilimumab. And so I think these will be all interesting studies to further enhance the field and answer some unmet questions that are out there.
I agree, Rana. That was a wonderful summary. Also, let's not forget non-clear cell histology and kidney cancer, a huge unmet need. And there is the SWOG 1500 PAPMET trial that has been completed accrual, and results are awaited comparing sunitinib to cabozantinib. There were other 2 arms in the study of savolitinib, a MET inhibitor, as well as crizotinib. Both these arms were stopped due to futility analysis. And now the study is finally will report out results of sunitinib in comparison to cabozantinib. The hope with that, with those results, is that hopefully it will establish a baseline for future comparison and will establish a standard frontline therapy for papillary metastatic kidney cancer. Other non-clear cell histology studies, of course, there is studies of axitinib and nivolumab that is ongoing in the translocation type kidney cancer. There is a study in the cooperative groups with that combination. And, there are more and more studies that are needed to look at these small incidences of non-clear cell histologies. The other study that is noteworthy is a combination of atezolizumab and bevacizumab in the second, third line setting in non-clear cell histology that showed fairly promising results. This study was led by Dana-Farber, and Rana, of course, is one of the lead authors on that. Any other comments?
Ulka, I think I want to highlight ICONIC trial also, which is run by Dr. Apollo from NCI. I think she did really a great work in terms of combining Nivo Cabo and also combining Nivo Ipi Cabo in ICONIC trial for rare GU tumor type. And among these rare GU tumor type, there is a number of rare RCC patients also can go into the trial. One of them is renal medullary carcinoma. This is a challenging subgroup. We still need to come up a good therapy option for those patients. And again, for collecting duct papillary rare subtypes can also enroll ICONIC trial, which asking the triplet in those rare population.
Agree. That is an ongoing trial and it needs to be supported.
So just several other quick studies for patients that have non-clear cell histologies. And so we have the CABO-SUN2 study, which is similar to PAPMED in terms of we're looking at sunitinib versus cabozantinib in the frontline setting, but we're including patients that have additional histologies as opposed to just papillary. And so we're accruing patients with chromophobe unclassified, and the only exclusions are for patients with renal medullary cancer or collecting duct. And a quick plug again for renal medullary cancer. This is a huge passion for my colleagues, Dr. Nazar Tanir and Pavlos Masal. We have a number of clinical trials for these patients. And so I think it'd be fantastic if we're able to continue to identify and treat these patients with this very aggressive disease. My final plug, and this is about cost, because I think that this is really crucial as we've talked about all these therapies. As it stands right now, I think it's just important for everyone to know that immune checkpoint therapy is currently covered under Medicare B. There's been some talks about moving it to Medicare D, which I think would be really threatening to patients. In Medicare D, many patients are on the hook for 20% of copays. And so I think it's imperative that we ask Congress to look at the ability for Medicare patients to accept copay programs, which they're currently not allowed to use, and to also consider negotiation of cost with companies.
Okay. I think with that, we will wrap up our peer exchange discussion. Thank you, everyone, for a very stimulating and exciting discussion. Good evening.
Thank you.